Thank you, Jennifer. So good afternoon, everyone. Thanks for sticking it out until the end. These are my disclosures, sources of grant support for our research and some consulting work. Okay, so this is the outline for the next 30 minutes or so. We're going to start off by talking about maternal mortality in the United States, which has really been the motivating force behind the use of early warning systems on labor and delivery units here in the US. We'll talk about the early warning systems that have been developed, and then talk about some of the data that support the use of early warning systems. We'll then talk about the implementation and some thoughts about how to do that of early warning systems. And then at the end, I'm going to close by talking about a slightly different topic, risk stratification, and a project that we're doing at the Brigham, a quality improvement project, calculating comorbidity scores on all of our patients as a way of identifying patients at heightened risk for adverse outcomes. So we saw this data this morning. The maternal mortality rate in the US is 26 maternal deaths for every 100,000 deliveries, placing the US 60th in the world. Our maternal mortality rate is double that of Canada, triple that of the United Kingdom, and 8-fold higher than the country with the lowest maternal mortality rate, Iceland. It's also, as we heard this morning, one of 8 countries where the maternal mortality rate has increased since the early 1990s. It's also an area where there's tremendous racial disparities, perhaps some of the greatest racial disparities in all of medicine, with non-Hispanic blacks having a maternal mortality rate that's 3.5 times higher than that of Caucasians. So this is data from the CDC showing the maternal mortality rate by race, ethnicity, and maternal age. And I'll draw your attention to that bar in the non-Hispanic black group that represents patients 40 years or older. So there the maternal mortality rate is 191 per 100,000 live births, meaning 1 in every 500 births to a mother who's African American and over 40 results in maternal death, a pretty staggering statistic and something where we clearly need to do better. This shows the proportion of maternal deaths attributable to various causes at different intervals. It's again data from the CDC. And I want to draw your attention to these conditions. So each of these conditions account for about 10 to 15% of all maternal deaths. They're about tied as the leading causes of maternal death. And this is going to be important in our conversation about early warning systems because the triggers that have been created are designed to identify patients with these conditions, the common causes of maternal morbidity and mortality. So importantly, we now have robust data to suggest that a large fraction of maternal deaths are preventable. This is data from the Maternal Mortality Review Committee in the state of California. They review all of the cases of maternal death and have experts look at the case and then ultimately come to a consensus about whether there's a good to strong chance that the outcome could have been averted with better care, some chance, or no chance. And you'll see this is the proportion where the committee voted that there was a good to strong chance that the outcome could have been different. And for several of the leading causes, preeclampsia, obstetric hemorrhage, venous thromboembolism, the rate of preventability was in excess of 50%. And if you further include those where there's at least some chance that the outcome could have been prevented with better care, the rates are even higher, 80, 90, and 100% in some for some conditions. So when these reviews are conducted, the theme emerges that many women show signs of deterioration that goes unrecognized. And really there are 2 key themes that come out of these reviews: denial and delays as being things that underlie the progression to severe morbidity and then ultimately to death. Denial regarding the seriousness of the maternal condition, and then delays in timely evaluation, timely diagnosis, and timely intervention. So why does this occur? Why is this a problem? Well, labor and delivery units are busy places. Unlike the operating room where we have 1 or a couple of patients that we're looking after and following their vital signs minute to minute, on labor and delivery we're covering 10, 20, 30 patients at a time, and so things can get missed. Young women also compensate well, so the changes in their vital signs may be subtle and out of proportion to the degree of the acuity of their illness until they fall off the cliff and they're really in extremis. Another consideration, I think, is that adverse events can occur in low-risk patients. So we know about half of hemorrhages occur in patients in the absence of recognized risk factors. And so bad things can happen to women who are otherwise healthy, who might not be on our radar screen as being patients likely to have bad outcomes. And then finally, vital signs are often abnormal in pregnancy. You all know a lot of patients have hypertension, tachycardia, even a little bit of hypotension after the epidural is placed that can make us not pay as much attention as we should to abnormal vital signs. So early warning systems are really designed to address this dual trap of denial and delays. They're designed to alert teams to abnormal signs and symptoms that may precede clinical illness, to prompt urgent and emergent evaluation of the patients by clinicians that can respond, and thereby facilitate early intervention that arrests the progression to morbidity or even maternal death. And as I mentioned, these early warning signs and symptoms, the triggers, are built around the common causes of severe maternal morbidity and mortality. So for hemorrhage, the warning systems pick up tachycardia, hypotension, altered mental status. For sepsis, fever, hypotension, tachycardia, hypoxia, altered mental status, venous thromboembolism, tachycardia, tachypnea, hypoxia, preeclampsia, hypertension and hypoxia, and finally cardiovascular complications, tachycardia or bradycardia, hypoxia or hypotension. So early warning systems have long been used in general medical and ICU settings. They really came to the fore in terms of use in obstetrics in the 2007 Saving Mothers' Lives report from the Confidential Inquiry into Maternal Deaths. So in the UK, every 3 years, all of the maternal deaths that occurred during the prior 3 years are aggregated and reviewed, and the committee that does that tries to derive lessons regarding how to improve maternal safety. And in this 2007 report, one of their top 10 recommendations was that maternal early warning systems should be developed and deployed at all labor and delivery units across the United Kingdom. As part of that report, they published these early warning criteria, which was derived from one of their hospitals that were part of in the UK, a hospital in Aberdeen. And basically, a patient will trigger will meet criteria for an alarm trigger if they have 2 criteria that are in the yellow alert category or any criteria in the red alert category. And you can see the different domains that are measured and the thresholds for having a positive trigger listed there. So this was really developed on the basis of expert opinion. There weren't data to inform the selection of the thresholds or even the conditions that were included. So this group, based out of London, did a study where they looked at the performance characteristics of the early warning trigger tool proposed in the 2007 report. They had 676 patients that they looked at. Of these, 13% had what was defined in the study as serious maternal morbidity. So they had a pretty liberal definition of what constitutes maternal morbidity. Most of the cases of maternal morbidity were either hemorrhage or patients with preeclampsia with blood pressures in excess of 160 or significant aberrations in their vital signs. They found that 30% of patients met the Muse criteria, were positive triggers for evaluation, such that the sensitivity of the tool that was described was 89%, meaning 89% of the patients that went on to have severe morbidity were picked up by the trigger tool. And the positive predictive value was 39%, meaning on average 2.5 patients would have to be evaluated for every 1 positive trigger that would go on to have a severe complication. So the authors concluded this tool has good sensitivity, has a reasonable trigger rate, a pretty high positive predictive value, and subsequently this has become something that's widely used in the UK and is now considered an auditable standard in the National Health Service. So here in the US, this idea of having early warning criteria really came to prominence with this publication from the National Partnership for Maternal Safety. So the National Partnership is a consortium of 19 professional organizations that represent practitioners who care for obstetrical patients. It includes SOAP, ASA, SMFM, ACOG. And they've come together to put together the bundles that you all might be familiar with, the hypertension bundle, hemorrhage bundle, VTE bundle, but also these early warning criteria. So this group used a consensus-based approach to define what they termed to be the maternal early warning criteria. They started with the UK Muse criteria, but then ultimately decided that they would develop a tool that would trigger on the basis of a single abnormal parameter. And the idea was to create a very simple, easy-to-use tool to avoid discretionary use. They were concerned that if nurses had to go through and identify whether a patient had 2 yellow criteria or 1 red criteria, that the tool wouldn't be used uniformly, and that might be a barrier to effective implementation. So patients will trigger based on a single abnormal vital sign. And then they said that the policy, the implementation of this should be accompanied with policies that define who to notify, how to notify them, and when and how to activate the clinical chain of command in order to ensure an appropriate response to a positive trigger. And this is what they came up with. So patients would trigger if they had a systolic blood pressure of less than 90 or greater than 160, a diastolic pressure of greater than 100, heart rate less than 50 or greater than 120, respiratory rate of less than 10 or greater than 30, an O2 sat of less than 95, oliguria, or maternal agitation, confusion, or unresponsiveness, and in patients with preeclampsia, an unremitting headache or shortness of breath. So the Muse and as well as the maternal early warning criteria were really promoted for use based on expert opinion that their use should improve outcomes, that they should be helpful in identifying high-risk patients where an intervention was needed. This study by Larry Shields and colleagues sought to test this, to determine whether maternal morbidity could actually be reduced through the use of an early warning trigger tool tied to clinical protocols for the management of common obstetrical complications. So they did a study in a 29 hospital system, Dignity Healthcare, in the western part of the US. They identified 6 hospitals as pilot sites that would implement the early warning trigger tool, and they took 23 hospitals that were part of their system as control sites where they'd be able to look at trends in the outcomes of interest. The tool in their protocol triggered the use of 4 treatment pathways for the most common sources of maternal morbidity: hemorrhage, hypertension, sepsis, and cardiopulmonary dysfunction. The primary outcomes in the study was the CDC-defined measure of severe maternal morbidity, which represents maternal end organ injury, as well as a composite morbidity measure, which includes both the CDC-defined severe maternal morbidity measure as well as various measures of hemorrhage. And they compared the rates of these outcomes in a 24-month baseline period prior to the implementation of the tool, and then a 13-month post-intervention period. So this was their trigger tool, and you'll note that it's different than both the UK MEOWS tool as well as the tool that's been recommended by the National Partnership. Its structure is very similar to the UK tool in that a patient will trigger with 2 abnormal values in the non-severe range or a single abnormal value in the severe range. And you can see these are the thresholds used to categorize a patient as having a positive trigger. So they found after they implemented the tool in their 6 pilot hospitals, there were 12,611 deliveries, and of those, just 260 were positive triggers, so a trigger rate of 2%, pretty low trigger rate. When they looked at the pathways that were activated, interestingly, sepsis was the most commonly activated pathway, representing 71% of the cases, followed by hypertension, hemorrhage, and then the cardiopulmonary pathway. So here are the results assessing the impact of the intervention. On the left-hand side here, we have the rates of the outcomes that they measured in the pre and post-intervention period at the pilot sites, and then on the right, the control sites. And they measured these outcomes during the same intervals with the idea that the non-pilot sites could serve as controls for any temporal trends unrelated to the implementation of the trigger tool that might account for changes observed in the pilot sites. So as you can see here, the implementation of the trigger tool and the clinical pathways in the pilot sites led to a statistically significant reduction in the CDC-defined measure of severe morbidity, the composite measure of morbidity, and the rate of eclampsia. There was either there was a trend or a point estimate decrease in each of the other outcomes that they assessed, including hemorrhage, transfusion, D&C, hysterectomy, and only sepsis. There was a non-significant increase following the implementation of the trigger tool. In contrast, looking at the control hospitals during the same time period, rates of the CDC defined severe morbidity measure, the composite morbidity measure in eclampsia were stable, and the rates of all of the other adverse outcomes actually increased during that same time period, suggesting that the changes that are observed in the pilot sites are due to a causal effect of implementing this tool rather than secular trends that might otherwise account for the changes observed. When they looked at the performance characteristics of the tool, it was highly sensitive for detecting patients that went on to be admitted to the ICU. The sensitivity was 97%. There was also a low frequency of triggering. As I mentioned, it was only 2%, which is important because as we think about introducing these tools, we don't want something that's going to introduce alarm fatigue. If it's constantly triggering in patients that are doing just fine, clinicians are going to quickly lose interest. This study really presents the strongest evidence to date supporting the use of the trigger tool, suggesting that it could have a real impact on patient outcome. I think an important caveat to the interpretation of this study is that it was really two interventions. It was the trigger tool, but it was also the clinical pathways. And I think really to be most effective, we would implement both components in our practice. So as we think about implementation, what are some of the strategies we can use to introduce these to our labor and delivery units? Well, one is to work with EMR vendors to build in the triggers. At the Brigham, when we adopted Epic, we actually built the triggers into the EMR, so there's a red flag that pops up for patients that have a vital sign that's out of range. You then need to develop a system for notifying responsible providers and figure out who the responding clinicians are going to be. Are they going to be the obstetrician or the anesthesiologist or perhaps representatives of both teams? You then need to adopt algorithms for treating these complications to make sure that when triggers occur and patients are identified as having a complication, clinicians know what to do and provide the best care for those patients. And then you need to reinforce a culture that encourages notification. Nurses need to feel like it's better to call than not to call. It's better to notify the responding clinician than to not notify. And this can be reinforced with regular audit and feedback. I think a challenge in figuring out what to do with respect to the use of triggers is which tool to adapt. We have the tool from the UK. We have the tool from the National Partnership. We have the tool that was studied in the Shields article. I would say our experience with the criteria that have been proposed by the National Partnership is that the trigger rate tends to be a little bit high, so I think it favors sensitivity over specificity. That's what we had built into Epic, but we're considering shifting to perhaps the tool that's used was used in the Shields article as a way of decreasing the frequency of false positive triggers. So in the last few minutes, I want to change gears a little bit and talk about another approach to identifying high-risk patients. So early warning systems are based on vital signs that detect acute deterioration, as we've just discussed. But I think it's also important to make practitioners on labor and delivery aware of the risks associated with patients' obstetrical and medical complications. And the idea is that if you can identify patients that are at high risk, it can allow thoughtful deployment of resources, thinking about nursing coverage ratios, who the nurses are assigned to cover, things like that. It can lead to heightened surveillance for complications, preparations for delivery, thinking about who needs to be around when the patient delivers to make sure the patient's safe. And then also, ultimately, to determine the appropriateness of a center for delivery. So if a patient's identified as being at markedly high risk, perhaps they should be referred to a tertiary care center. So our group developed this Comorbidity Index. We published on this, I guess, about 4 years ago now. We took nationwide Medicaid data and identified a really large cohort of patients, numbered over 800,000, 1.2% of whom had severe maternal, an outcome of delivery that resulted in severe maternal morbidity, meaning maternal end organ injury. We identified 20 maternal conditions that were associated with severe morbidity, and then based on the strength of the association of those conditions with severe morbidity, assigned a point score, and I'll show you how that works in the next slide. So The idea is that patients with pulmonary hypertension are obviously at much higher risk for having severe morbidity than patients that have asthma. So the number of points assigned to pulmonary hypertension in the scoring system is greater than what asthma receives. Ultimately, all of the points associated with the different conditions that patients have are summed up to provide a single OB Comorbidity Index score. So this is a table from the publication. So the strength of the association of all of these risk factors for severe morbidity are represented in the beta coefficients. This was defined in our data. And then on the basis of those associations assigned a point value. And we found when we took this point scoring system and applied it to a replication data set that there was a strong association between the maternal comorbidity score and the occurrence of severe morbidity. So as patients have higher and higher scores, their risk of maternal morbidity goes up, and those that have scores of 9, 10, or greater have a risk of severe maternal morbidity in excess of 10%. And we replicated this analysis looking at ICU admission and saw a very similar pattern. Our score was subsequently validated by a group in Canada. This was published in the British Journal of Obstetrics and Gynecology a couple of years ago. They looked at just under 6,000 deliveries that occurred in Alberta, Canada. They implemented the score in their patient population and found that it had very similar performance characteristics to the Medicaid population. They also found that the score performed just as well if the comorbidities are defined at the time of delivery as if they're defined at any time point across pregnancy, suggested it really could be used at the time of admission to labor and delivery to risk stratify patients. So over the past 4 or 5 months at the Brigham, we've done a multidisciplinary quality improvement project that's involved the obstetricians, the nurses, and the anesthesia teams. We calculate an OB Comorbidity Index score on all patients on admission to labor and delivery, and that's done by the labor nurse caring for the patient, and then at each change of shift for the nurses. If the patients have a score of greater than 6, which corresponds to about a 5% risk of having a morbid outcome, the responding clinician is notified. We also use the score during our multidisciplinary rounds. So in our multidisciplinary rounds, the nurses present the patients, and so they'll start off by saying, Mrs. Smith is a 30-year-old G1 P0 at 39 weeks. Her CMI is 5 because she has asthma and obesity and chronic hypertension, something along those lines. We're currently doing a formal assessment of the performance characteristics of the tool and when it's used in a clinical setting, and also assessing the way in which it impacts on awareness of patient risks. But the feedback that we've received, the informal feedback we've received from nurses and the obstetricians is that they find this to be a very useful way of raising awareness of high-risk patients on labor and delivery, as well as raising nurses' awareness of patients' comorbidities that might inform their management around the time of delivery. And this is just an example of the worksheet that the nurses calculate. We're eventually going to build this into Epic, but nurses just go down and circle the number of points corresponding to the conditions that the patients have, sum up the score, and then indicate whether they notified the MD if the score was over 6. And then we display the scores on our grease board so that everyone on the unit is aware of patient risk levels. So take-home messages. So I think early warning systems, based on what we reviewed, can help identify patients at heightened risk for deterioration. When tied to clinical protocols, they've now been demonstrated, based on the study from Shields and colleagues, to decrease maternal morbidity. It's important to note as you implement these, there will be false triggers, and you really need to encourage a culture where it's better to notify than to not. And then finally, the OB Comorbidity Index may be a helpful tool for identifying patients with high-risk conditions and raising awareness of the L&D team of those conditions. So thanks very much for your attention.